Hello everyone, how are you doing today? I feel very privileged to speak to you all. It's been really exciting to listen to, to listen to different people who are dealing with patients along the different touch points of that patient's journey. And I'm quite excited to tell you how we as osteopaths deal with our particular touch point. And what's really amazing to hear as well, I think 150 years ago, physiotherapists, osteopaths and chiropractors would have probably had quite a different opinion on how to deal with patients, but as we're all coming together and we're all sharing ideas and evidence, we're all more or less doing the same way, but as an osteopath I will be biased towards osteopathy philosophically. So let's start. So my name is Elliott Reid. I'm a counsellor for the Institute of Osteopathy, which is contributing to building awareness and also to understanding the perception of osteopathy in the public, and also contributing to research as to how osteopathy is benefiting our patients. And I'm also the founder of the Revitalise Clinic, where we've helped over 10,000 people become pain-free medically, or help people to become pain-free, mentally well and physically fit. So the types of patients that we would see at Revitalise tend to be chronic. They've gone through the system, they've tried a lot of things, and they come to us based on our reviews and our approach, and it's a lot of the time their final punt to see if we can do anything about it. We see a lot of chronic lower back pain, radiculopathies, a lot of patients with comorbidities as well. So then the question is, how do we approach this? Now, the most important thing is that we see the patient, the human being, the subjective sense of reality as the priority. That is the context, that is the stage. We see patients who happen to have back pain rather than treat back pain. It's really important, and I'm going to go on to why that is in a second. So pain is a lived experience, most often uncorrelated to anatomical findings. You might have seen the research to show that radiologists, for example, can't predict who is going to be in pain based on generative findings over the next 5 or 10 years, and they can't predict who is in pain unless there are more severe findings on the MRI. Most of the patients that we see, most of them are at work, most of them are able to do certain things, but pain is heavily affecting their quality of life. Quotes from A.T. Still, the founder of osteopathy: "To find health should be the objective of the practitioner. Anyone can find disease, and our job as practitioners is to try and find health within that patient's subjective reality." And this quote, "to find health," or the body has its own medicine chest, is very, very similar to the other therapeutic language that was coming out at the time. So, for example, Sigmund Freud, famously, so the founder of psychology or psychotherapy, famously said that the conscious mind is like a flashlight that if shines light onto an unconscious lesion, so using more allopathic language, after the conscious mind has shined light on the unconscious lesion, the mind can find its own resolution. So the idea that we have what is within ourselves to make a recovery, and we as osteopaths work with that as much as we can. Research shows that the pain lies in the patient's subjective experience of their mind, their body, and their environment, i.e. the biopsychosocial model. For example, like I said, MRI's findings can't predict the onset of back pain or the existence of back pain often. Diet is highly correlated with pain and inflammatory conditions. There was a fantastic literature review conducted by Colin et al. In 2018, and they coined the term pseudo-injury, this idea that someone can be in pain because of their lifestyle factors rather than physiological contributing factors. Or, for example, Dr. Matthew Walker, in his book, Why We Sleep, he quotes research showing that sleep deprivation, stress, anxiety, these can increase inflammation and increase someone's anxiety, or increase someone's sensitivity to pain. And I think it's important that we view pain as a defense mechanism. It's the way that someone's mind nervous system is trying to protect them from themselves, just like anxiety or fear is trying to protect that individual from their outside environment. So because we are dealing with a very multifactorial picture when it comes to our patients, we aren't going to treat a patient with lower back pain the same way as you might see in more of an allopathic situation. So rather than there being a pill for an ill or a treatment for a finding, it's more about this patient is going to go on this journey. We understand where they are, and we understand where they want to be, Our understanding of where they are is informed from the consultation, this consultation being a conversation between two experts. I might be an expert on how to get someone out of pain. They're an expert on their experience of pain, and they're going to go on a journey towards their actualization or towards the mountaintop. And that might be that they want to be able to pick up their children again. They want to be able to play sport again. They want to have a good night's sleep again. And if we envision this journey as going through a tree tunnel, the circumference of that tree tunnel, that's where the evidence really comes in. And we're going to talk about that in a second. So, for example, evidence may suggest that the most effective painkillers for back pain are opiates, NSAIDs, and other analgesics in certain settings. Discectomies and laminectomies are effective for emergencies such as caudal equina syndrome or unresponsive radiculopathies with over a 50% myotonal deficit, for example. But what happens when individuals don't fit that category and pain is affecting them 24/7, every day of their life? It's affecting their relationships, it's affecting how they view themselves, it's affecting their autonomy, it's affecting their entire lived experience. And that's where we come in, and we are trying to build a journey between where they are and where they want to be. So, evidence informs the path. So this is similar to what Avni mentioned when it comes to communication. So if it is practitioner-centered, and it's really, really important when it comes to the management of chronic pain that it's not practitioner-centered, it has to be patient-centered. So the way that I view this, some of you might be familiar with the hero's journey, the idea of crossing the threshold, going into the unknown, going through a process of trying to find your way to the ultimate boon. So it's very common. The hero's journey is very common in metaphysical or psychotherapeutic circles, but it's also very, very relevant in the pain setting. So this idea that the patient is the hero. The patient is having to step into the unknown. They're having to do things that they haven't done before, they haven't done for a long time. And with the help of a guide, which is us, the practitioner, not the hero, the patient's the hero, we're the guide. With the help of a guide, we can help them to reach to where they want to be. So if we're going off that path and outside of that tree tunnel, if it's practitioner-centered, it'll be, scan reveals this, I need to do this to you. Now, if it's patient-centered, it's collaborative. We're going to work together towards your goals. There might be some unpredictable findings, there might be some downs and some ups along the way. I'm going to be with you every step of the way. Off the path, purely reliant on practitioner intervention, I'm going to treat or prescribe this. On the path, patient-centered, combines interventions based on the weight and ease of the intervention. This short mobility routine will fit your daily regime. Adding this into your diet can help to reduce inflammatory levels, it can help you to feel good, it can help you towards your journey, or on your journey. All right, so let's go through this in a little bit more detail then, if we bring all this together. So, patient comes, and next slide, we've got a patient who came into the clinic with a lumbar radiculopathy. All right, so early stages. Patient comes in, and they're in pain. Manual therapy. What does manual therapy do? So you might have seen a lot of videos or images of us as osteopaths using joint manipulation or massage or articulation. Now, when it comes to, I suppose, the holistic view of it, you might say that we are providing a novel experience of movement. The patient hasn't been able to flex their spine pain-free for a long time. We are offloading that, we're doing it for them, and we're providing a therapeutic experience of lumbar flexion, which is comfortable, pain-free, which hopefully then carries over into a functional setting. But the most important thing is that we need to teach the patient how to do the same thing themselves. How can they at home start to build this capacity for movement that they've lost, starting most of the time non-weight bearing and then coming on to more weight bearing later down the line. Health efficacy, education. I had the pleasure of having Danny Miller, who is an osteopath, but he's also a health psychologist, came and delivered some CPD at the clinic in Kent, in Gray's Inn. And he mentioned something very, very interesting. He said that health efficacy, someone's empowerment over their health, someone's knowledge of the situation that they're in and the presentation that they're in, is the number one, has a number one correlation to that patient making a successful turnaround. The more empowered they are, the more they know, the better that they're able to help themselves. And then also this, to be able to guide medications. There's a lot of patients who we see who are lost in the system. They've been on opiates for far too long. They've been prescribed non-steroidal anti-inflammatories for a condition which is chronic, is very unlikely to be going through an inflammatory stage. So educating them on the medication that is probably more appropriate for them, asking them to go back to the doctors for some medical consultations, that can be quite useful as well. But we have this balance. We have this balance of pain relief, which is good because we want our patients to feel as comfortable as possible. But the other is that we need that capacity. So the question, how do we build capacity? The pain reduction helps them to experience life in a more comfortable setting. But if they don't have the capacity to go on with it, then unfortunately they're not going to be able to do too much. Then how do we build capacity? So one might be basic strengthening exercises, further education of the process, looking at sleep and dietary advice once again, sleep and dietary advice to reduce the catastrophic experience of pain. If they're better rested, they feel better in themselves, and they're going to be able to deal with their pain a lot better. But then, as well as that dietary advice, how can we improve, how can we shift their diet onto maybe more of a whole food diet where they're able to reduce the amount of circulating inflammation within their body? And then if it's more, if we're dealing with more of an athlete, then we're going to be looking to more sports-specific movements, return to work advice, recapping on education, and then easing off treatments. It's very, very important that we make our patients independent of us, that our patients aren't relying on us for treatment, because if they're relying on us for treatment, then once again, we become the heroes of the journey, and it's really important that our patients become the hero of the journey, independent from the guide, and that they're able to live their lives independent of us. All right, so just make sure I've got everything here. Okay, perfect. Right. When it comes to relational skills, these are what really help us to step into our patient's subjective reality. There is going to, if we can't build rapport quickly and effectively, there's certain things that our patients might be holding back from us. There are certain things that we might miss, and there are certain things that we on both sides, say myself and the patient, might miscommunicate or might misunderstand. So these are some of the ways that I use some psychotherapeutic and some more communicative skills to help me communicate to my patients. So motivational interviewing, I might use a little bit of motivational interviewing, and it might go like this. So a patient says to me that they feel that they might be in pain because they don't move enough. Now, if I dismiss that, I'm missing a little bit of a trick. If I ask them, well, tell me more about that. You said you wanted to exercise more. What do you mean? Well, I think that if I was just able to, maybe walk the dog a little bit longer, then I might feel better. Oh, why'd you say that? That's interesting. Because I feel a bit better after I move and after I exercise. Oh, do you think it would be a good idea then if we just write that down and we schedule it in that you're walking your dog another 10 minutes a day? Yeah, I think that would be a good idea. So I'm guiding the conversation via positive reinforcement and inquisition in the direction that I think would be good for that patient's outcome. Or it could be the opposite. So you actually do the same thing for negative reinforcement as well. That could be, sometimes I think that my fear is the thing which is getting in the way of my goals. Why do you think that? Well, sometimes I don't move, not because of how much it hurts, but because how much I expect it to hurt. And then you can, once again, guide that conversation using motivational interviewing into an outcome that would be beneficial to the patient. Labeling. Labeling is a great way to build rapport. You seem quite anxious about this, or your pain seems to be really getting you down. This is the way that you can make the patient feel seen and feel heard. And that is something that we see patients coming in as being quite a dissatisfactory experience that they might have experienced before. I hope they don't experience that with us, but they might have experienced it before where they feel like they're not being listened to or no one's taking them seriously or they're being dismissed. Kindness was something that was reported to us as being one of the main reasons why patients come to us. Reflecting on our own experience to say that we've been where you are and we've seen it through. We've seen other patients who have been where you are and they've seen it through. That can provide a nice anchor in reality as well. And then the mentorship and leadership which we've gone through. All right, so let's go through this patient presentation. So his name's not Mr. Smith, but we'll call him Mr. Smith. So, right, subjective is lower back pain with ridiculous symptoms, left leg, 18. It's been going on for a year and a half. On examination, slump test positive, chems test positive, deficit in the S1 myotome, and biopsycho. So this I thought was really interesting. The patient came in, and say if I saw him now, and his pain started last year, March. I asked, the guy's in severe pain, and I asked him, was there any trauma which preceded your pain? No. Any increase or reduction in exercise? No. Okay, was there anything emotionally that changed in your life at the time? Oh, it's interesting you say that. My wife was diagnosed with terminal cancer. Okay. How are you coping with that? And he said, well, I thought I was coping with it quite well. And he starts to cry. And then we have a further conversation. Do you feel like your behaviour might have changed since, or do you feel that your moods are related to your pain at all? When I get really down, my pain seems to get worse. And since my wife has been getting more ill, we're going on less walks. I'm not going out as much. So let's bring it back. I'll present this to you. We've got a patient who is not going out as much. They're not moving as much. They are experiencing low moods. What do you think is going on here when it comes to his pain presentation? Any answers? Yeah? Sorry? More, why? Yeah. Yeah. Yeah? Linking back to what you said, Avni, about the catastrophization of his experience. Now, could we bring this more anatomically? Could we say that, for example, if he's walking less, he's probably going through a bit of atrophy, pain being a defense mechanism, anxiety, grief, also defense mechanisms to protect the self against the environment. Is there a little bit of a bleed over between his defense mechanisms, i.e. his moods and his pain? Maybe. Loneliness. Individuals who are experiencing loneliness are more likely to have a poor experience of life, more likely to be in pain. So the question is, once again, we understand where he wants to be. He wants to be pain-free, he wants to be comfortable. Later, it evolves as well that he actually wants to have a better experience of life. He wants to get out there again. Okay, so what do we do about it? It's time to build that tree tunnel that we spoke about on the way to his journey. So, advice and consultation. We provide an explanation for chronic pain. Once again, bringing back to that very old quote from Freud, we use a conscious mind to shine light on the unconscious lesion. We bring to light what might have been missed in his mind before. It helps him to deal with it, helps him to confront it. We present a strategy for his goals, milestones on the way to where he is. So we're structuring, bringing order to chaos. We're structuring his path in his journey up that mountain. Pain modulation, we use nerve floss techniques. So some of you might have seen it, for example, where if this is a slump test, but if I do this, then I'm flossing the nerve because I'm running the nerve from the attachments in the brain down. So the nerve is moving rather than being stretched. It's shown to be quite relieving for nerve pain. Advice on neuropathic medications. If he has a radiculopathy, but he's been given naproxen or ibuprofen and he's not sleeping, it might be that if we advise him to go back to his doctor and maybe get some amitriptyline, that might be a better thing to do. Manual therapy to reduce pain, provide a novel experience of movement, and to provide an experience, obviously, of recovery as well. And when it comes to function, so we're able to reduce his nerve pain. And one thing that was quite nice, because unfortunately, because of the radiculopathy, he's testing positive on a Trendelenburg test. He didn't have very good balance. He was falling a lot more. And I gave him some exercises, just like standing on the spot or just doing some like single leg weight bearing exercises. But he wasn't too enthusiastic about it. So I asked him what he'd like to do with his wife. He said, I really used to like to dance with my wife. So I gave him an exercise of just a two-step, but just asking him to stand on his leg a little bit more just to try and improve. And that worked really well. And he's now seeing us regularly more for exercise therapy now, which has been great. And he's joining more social groups. He's having a really good time, and we're able to see him through this process. And that's very reflective of what we do at the clinic, is taking that whole human, not just the pain, the whole entire being, and trying to elevate their experience of life. And right, so just to summarize, so osteopathy, I love being an osteopath. I'm very passionate about being an osteopath, and I'm very happy to see that patients are passionate about coming to us as well. So 96% of users of osteopathy have had a satisfactory or very satisfactory experience of osteopathy. Osteopathic treatment has shown to reduce the need for spinal surgery and other invasive procedures. Patients value the medical support with a holistic perspective. And health efficacy, empowering the patient through knowledge and intervention, has been highly valued and also is very effective. And interviews led by myself amongst the patients that we see found that patients valued kindness, expertise and strategy-led outcomes over all other factors. So it's been a pleasure speaking to you today. I'm just going to close with a quote that the president of the Institute of Osteopathy, Glynis Fox, was kind enough to send over to me. The practitioner's task is not merely to explain and treat, but to provide support and insight into the meaning of illness experiences in order to enable a patient to develop a better life-enhancing narrative and become a more whole person, which I thought was beautiful. Thank you so much for listening to me. I appreciate your time.